Before we move ahead, you just, did a wonderful activity to engage our audience, but this time I have one amazing activity.
Okay.
So allow me one important thing that I need my audience attention this time. So if we talk about, okay, thank you. So if we talk about, I need some suggestions from my audience that what do you think is the legal age limit to get IVF under our ART Act 2021? I need some audience engagement here. Any raw guesses?
Okay, you'll have to give me the mic and you use that one. Okay, so I think I'll give my 2 cents first. 18. Okay, I want to do 18. नहीं मैम तो हंस रही कह रही है जैसे कुछ नहीं पता इसे. No, it's okay. I'm fine. Thank you, sir. The intention is the same. But anyway, so now I want from the legal experts here. What is the age, the legal age? Anyone? Huh?
45 for female,
45 for female. And?
50 for male.
45 for female and 50 for men. Okay? Are we close, sir? पता नहीं. ठीक है. Anyone else? Yes, ma'am. What do you think?
For female and 50 for
45 for female and 50 for men. Anyone has a different answer?
50 for females and 55 for males.
Brilliant. So it is 50 and 55. Wow. Now we are getting into a discussion about this. Okay. Anyone from, ma'am, you have a different opinion? Anyone? Oh, there is someone with a different opinion. Yes, sir. हाँ ये तो हुआ 50 मैं तो खुद ही कंफ्यूज हो गया. This was?
after ART only 22.
This was in 22. Okay. So abhi the final answer is, ma'am, we agree with her, which is 54. Ma'am, Google नहीं करना था. ये बड़ी cheating. That's you. Right. So Google नहीं करना है. Without Google, you have to tell me. No, ChatGPT also. So what is the right answer as per you?
I said 50 for female and 55 for males.
Acha, and you reversed it. 50 for males and 55 for female. Brilliant. Nahin. Okay. Oh wow. Brilliant. We're not getting anywhere. This is not taking us anywhere. And
But,
you can,
but if I have to ask, what do you think is the legal age for this, according to you?
according to me,
Yes.
forget it.
ठीक
Just
है.
give us some options. I think this is like Kaun Banega Crorepati, so give us some options.
Sure, we have the options on screen.
Okay, here we go.
These are the
So,
options.
so you were saying 50. So basically, there is a age bracket which is being dealt with. It's rather not a single age. Okay, now, my God, this is really Mili Juli Sarkar here. Okay, C. You think is C? C, B, C. Oh my God. Okay. How many of us are thinking it's B? Give me a hand raise. B is majority. C, how many of you think it's C? Some of us. So B is majorly where Janta is, but there are some lone wolves as well on C.
So the correct answer is B. Our majority of Janta is right.
Okay.
It's women from 21 to 50 years and men from 26 to 55 is the correct answer here, according to the ART Act 2021.
So I think he was 50 नहीं आप भी ठीक थे आप दोनों ही ठीक थे मिल तो okay ये wrong है okay I think ये टीचर गलत है हाँ sir please tell me now okay now I will take the final decision from this man here.
So it's the age of marriage is 21 years. The only lacuna here is that in surrogacy, which came the 21st of June 22, they have written 18 for the woman. But actually, as per the act, which had got the assent of the president on the 7th of June, it is 2150 for the women and 2155 for the men.
2155.
Yeah, so 2155.
So 2150 and 2150.
This is for ART, not for surrogacy, of course.
Okay, brilliant. So the final is 2150 and 2155. Okay. ठीक है. Huh?
Listen, I'm quite shocked about this here. It's all, we don't have any mistakes about that. Surrogacy and the ages are different. Here we have got in ART Act, it's always 21 and 50 and 21 and 55 period. That's it. You can check the ART Act. Correct.
Brilliant. I love discussions like this. You know, at least this is where we know that everybody, see, generally in these conferences, half the people are sleeping, sir. But this is the brilliance about the VOH conference, that everybody is so awake and so into action. Thank you so much, ma'am. This really brings life to the entire discussion, but we also get it right now, though no intention was intended there. So with this, I think we will get into our next session, since all of us are so with us. Ladies and gentlemen, this next one that we are getting into is...
The Fertility Divide, Breaking Economic Barrier. And since we have spoken about science, innovation, ethics, and regulation, but at the heart of it lies a question we must ask with courage. Who truly gets access to IVF in India? And in this panel discussion, this question is going to answer, and we'll, getting to hear so many of things related to this. Because while technology has opened new doors in fertility care, the cost of walking through these doors remains incredibly high for most. For many couples, the emotional roller coaster of IVF is made even harder by the financial burden it carries. And what's worse for many, that the burden stops the journey before even it begins. And to shed light on this, we would like to invite a set of panelists for this discussion. Dr. Rohan Palshetkar, Unit Head, Bloom IVF Professor, D.Y. Patil School of Medicine. Let's welcome our speakers with a round of applause. Dr. Gunjan Gupta Govil, Founder and Director, Gunjan IVF World. Welcome, ma'am. Thank you so much. Mr. Vikas Anand, CEO and co-founder, Safety Insurance. Dr. Mohan Raut, Clinical Reproductive Immunologist, Dr. Raut Center for Reproductive Immunology. Welcome, sir. And to guide this important conversation, let's welcome our moderator, Dr. Navina Singh, Center Head and Senior Consultant, Birla Fertility and IVF, Mumbai Network, Chapter Secretary, Greater Mumbai Indian Fertility Society. Let's give them a warm round of applause. Over to you, ma'am.
Thank you. And a very good afternoon to all. So starting with this extremely interesting panel, as access to fertility care continues to expand, and I think so too must our conversation around it also, and mainly that who all can afford it, who cannot, and how it can be covered in the insurance, and what is the difficulties we are facing. And very important, that is equity just a buzzword or but a reality? In a very recent article, I think we all have, might have read it, that UN reported India is now the world's most populated country with 1.46 billion population. But a very surprising fact which came out, that our total fertility rate is dropping, and unfortunately now we are below the replaceable fact. That is 1.9 and the replaceable one is 2.1. So it all amazingly gives us a clear idea that it conceals sharp disparity across regions, economic classes, and social groups. When we talk about the fertility treatment, starting from egg freezing, from IVF treatments, surrogacy, it comes with a huge cost. And today we will explore where the gaps are there in the innovations and how, as a stakeholders, as a clinicians, as insurers, as a policymaker, how can we bridge this gap? I am joined today by exceptional panelists and experts who will bring their lens to this unique topic. So I will start the panel discussion. My first question goes to Rohan. So what you feel, Rohan, is the financial barriers, and what is the most significant limiting axis, which is preventing the access to the IVF today, and how we can optimize the cost without compromising in any clinical service what we are providing.
Absolutely. I think that's one of the main points which is brought up most of the times when it comes to access to IVF. I think this discussion's been there since the 90s. It's not something that's come up right now. But when we do look at it, the main, I think, biggest barrier when we look at it is the high cost, and it's out of pocket. Whenever we look at any IVF cycle, it's going to cost anywhere, say, from 1 lakh to around 3 lakh rupees. So whatever said and done, the patients who are there, they may not be able to afford it. The drugs, the lab equipment, I don't blame the clinicians either, because at the same time, we are making such a big investment into these machines, which aren't cheap to acquire either. So that's one of the biggest barriers that comes into play. Number two is lack of public funding or insurances, which don't really end up covering the costs of IVF. If you look at European countries like Belgium, Denmark, they cover close to around 3 to 6 IVF cycles, either under public funding or through private insurances. Even Australia. In fact, in the US now, 15 states, if I'm not mistaken, are 20. Exactly. 20 states have made it mandatory for insurances to cover IVF. So once all these factors come in, that's definitely going to improve the access. Another point is that when I just said 1 to 3 lakhs for an IVF cycle, but what about patients who are in the rural areas who need to come down to the urban areas or even semi-urban areas to go for IVF? Their travel costs, their stay costs, all these also add on to the overall cost of the medication, the cycle, and these genuinely become pain points for the patients. A simple thing that when you're looking at an IVF cycle, you say, okay, it's going to cost somewhere between 1.5 to 3 lakhs, but what about the adjuvants that we give? What about all of these? Those are small add-ons which we don't take into consideration because they're not affecting the centers. But for the patient, that definitely does play a point. Now, when you talk about optimizing the cycle while considering at the same time maintaining, maybe we think about stimulation protocols which could be less expensive in terms of, say, a PPOS cycle. Or considering now that we've got an oral antagonist that's come in, that could reduce the cost. Mild stimulation. Maybe consider IVF for good prognosis patients rather than considering ICSI for these patients. Maybe a public-private partnership could also play a role in actually managing these patients who can't really afford it, because if some of the funding that's covered is there, then in those situations, it can be covered. Now, Dr. Sadhana Desai has created an endowment fund for which IVF centers can actually apply to, and they get about 50,000 to 70,000 rupees, which can be waived off their IVF charges if you apply for it. So there are facilities available which can help optimizing without actually affecting the success rates as well. Another thing, I don't think we should end up standardizing protocols that one size fits all. I think becoming more precise, considering the different conditions of the patients, tailor-making the treatments would actually make the treatment optimal and also possibly reduce costs, because then we know. I think most IVF centers end up following ICSI for all rather than going in for IVF. So in patients where it's a young patient with maybe a mild male factor, you could consider IVF rather than considering an ICSI, where again the cost factor could change. Maybe not consider freeze all. Again, think about fresh transfers where the freezing cost could be saved for the patient as well.
Absolutely agree, Rohan, and especially when you said that we have to cater the population which are economically vulnerable and they are coming from the rural part. Now, going ahead, my question comes to Dr. Mohan Raut, sir. As just Rohan said, that an approximate IVF cycle ranges from somewhere between 1 lakh to 3 lakh. But what about the complex cases? What about the immunological complex cases where there might be need of more add-ons to the treatment? And giving the high treatment cost specific to these cases, what policy or what framework can be designed to support the access for these patients?
Excellent question. Before I give my answer, I am thankful to the organizers, Dr. Talwar sir, IFS, and all the organizers for inviting me here, because I am the one who is not doing IVF among all those who are doing IVF. I am a clinical reproductive immunologist, but maybe we see the maximum number of patients who have failed IVF. So therefore, I am eligible here to speak on their behalf about what can be done to make IVF more affordable. Now here, making affordable has one more angle, not just reducing the cost, it is also reducing the failures. What is the cost of the failure? That has to be taken into consideration. We can't just say that you reduce the cost because you can't compromise on quality. I know there are people, doctors here, Dr. Rohan Center, who provide services, what is called as a budget IVF, where they provide excellent services at a lower cost with excellent results. But the cost of failure must be kept in mind. And why this is important is because there are three things I feel related to IVF, which is we have to consider when we consider cost. Because one thing is social problem, fertility or having a child is a must socially. So come what may, if IVF is required, I have to do. Second fact is IVF success is limited. It's not unlimited success. So you have to be aware of that. And third is IVF is costly. So these three things you have to keep in mind, and therefore we have to have affordable IVF. Now, Dr. Navina asked about reproductive immunology. Is there any role of immunology? Because we have been working in this field for more than 30 years, and we have treated patients who have recurrent IVF failures. Again, there are three things related to immunology I would like to tell you. One thing is reproductive immunology is a super specialty. We are never taught about this in our undergraduation, post-graduation. So it is not expected for every gynecologist or IVF doctor to know about it. And if they try to dabble into it, they are likely to fail. Okay. Second thing is, so therefore you require special training in reproductive immunology so that you can help these patients who have failure. And third thing is, you have to incorporate the right diagnostic and treatment tools in your practice so that you can help these patients. So, coming to making this IVF affordable, I feel all of us are aware or agree with me, you will agree with me that immunology is important in pregnancy. All of you say yes. So any abnormality in immunology will lead to problems in pregnancy, yes. But when it comes to clinical practice, not all accept this fact that if we correct these abnormalities, there are chances that patient can conceive successfully. So therefore, I feel the right diagnostic tools which can help us to diagnose a couple who has problems related to reproductive immunology and implement it in time. Now, at what stage it should be done is individual doctor's choice. Because if I tell you the stories, you will be shocked. We have got patients who have 17 euploid embryo transfers, not conceived a single time, or conceived 7 times and miscarried, and she had been told about reproductive immunology. Her investigations indicated that she had problems related to alloimmune problem, and she is now under treatment. Patients who have multiple miscarriages who have never been explored for immunological problem. So therefore, I feel at right time, if the implementation of immunology is done, then it will definitely help in reducing the number of cycles. So even if your individual cycle is little costly, but it is more effective, patient is not going to undergo 5 cycles to be successful, maybe in the first or second cycle. Because we are now getting patients after recurrent IUI failures. Certain doctors are sending to us before even planning IVF, and some of them don't require IVF. And they just conceive maybe next IUI or naturally. Or patients who have multiple IUI failures, who have been treated immunologically, have conceived naturally. So what I mean to say is, rather than just reducing the cost of IVF, if we reduce the cost of failure, then we will definitely help these patients and saving money and also help them achieve their goal of having a baby.
Thank you, sir. So ideally, what you want to say that we have to be very specific in understanding that when patient should be, what is the correct time that patient should be investigated, should be advised for the correct treatment so that it reduces the add-ons, reduces the time to pregnancy and unnecessary expenses. Now, coming to the next question to Mr. Vikas, and I think you are the center point of this whole topic of the panel. We all know that, according to you, it's specific as an insurer, infertility is a medical requirement or it's just a lifestyle choice in the eyes of insurer? That is my first question. And what are the key factors which is still preventing the insurers to incorporate IVF into the policies? And what all can be done at a broader level to achieve this at the earliest?
Thank you, everyone. Before I answer those specific questions, I just want to give you a context setting in terms of the kind of products which are available across geographies. So in the biggest insurance market, that's US, the insurance for fertility is provided largely by corporates through employee benefit schemes. Plus, there are 20 states where it has been mandated by the state to provide insurance for fertility. This has been a kind of a very important for the fertility industry, because what we see is that in these 20 states where the law has mandated to provide fertility insurance, the number of IVF cycles, the number of clinics, IVF clinics in these states are 3 times the states where there hasn't been mandated. So they definitely, from a solution perspective, from the industry perspective, insurance plays a very, very important financial hedging product. If I go beyond that, if I go to Japan, there was a program which was started by the government 3 years back, where the insurance is provided by public funds, and it's a kind of a copay. Nearly 30% of the payment is paid by the individuals, and the 70% is paid by the individuals. If you go to Israel, which is the best landmark, where infertility treatment is provided by the state to all females, unlimited times up to an age of 45. But beyond that, if you go to Europe, except for the public funding, there isn't any financial insurance product which can take care of these kind of treatments. And now going back to the reasons why that's happened, definitely the first is what you mentioned, the perception of IVF as a lifestyle or elective treatment. Most of the insurance companies would view IVF as a non-essential compared to a core kind of a thing. Also, in India, the regulator hasn't given any kind of a mandate to cover this kind of treatment. So this has basically reinforced this kind of a perception. Also, another big thing why we don't have an insurance product is moral hazard and the adverse selection. So there is a feeling in the insurance industry that the people who need this kind of a treatment, the high risk clients, would be going for this kind of a product, and which will impact the profitability and will have an adverse claim ratio. Also, for insurance to come up with the pricing for this product, it's very much dependent on the data. You have actuarial sciences which gets into cuts, dice from city, age, lifestyle, and come with the pricing. There isn't any kind of pricing data or the data available, and we talked about the lack of data available in the country, where they can use this information to appropriately price the product. And finally, the cost variability, unpredictability, and also the claim volatility. So the rates are different, the success are different. So because of these reasons, it's very difficult for insurance companies to price that product.
Why I will not totally agree with you, but I would also like to have clinicians' point of view. There are insurance policies offered by the CGS to the government employees for IVF under the strict very rules. So why some are getting it? As per the ART law, Surrogates are being covered under insurance. Why not the patients? They are also taking the treatment. So if a surrogate, if a donor can be covered under insurance, why the patients not? I really want to have a view from your side and also from the clinicians that do you agree or do you disagree that whether the patients don't need this?
No, actually, I think there is a difference here. When you're talking about surrogates being covered under medical insurance, it is the pregnancy which is being covered. So even the pregnancy of the patient is covered. We are here talking about the IVF treatment being covered under insurance. Of course,
Donors are covered in the insurance.
even they are covered under medical health insurance, like not for the treatment. So there is a difference. So whenever we are talking about insurance here to reduce the cost, we are talking about an elective procedure being planned. There is no emergency in it. We are going for a planned IVF treatment. And is the medical cost being covered? So under insurance or not insurance, that is the question, because that is a very, very important question as far as Indian medical fertility industry is concerned. Because here we are not being covered by most of the insurance companies. And though there is a change which is coming, because if we are covering under insurance, because there are a lot of, I know about media houses who have got egg freezing done on their cost, because they expect the lady to join and work with them for another 4-5 years, which would lead to a decline in fertility. I cannot take the names publicly, but I have had these people coming to me, and that is how I came to know. So people are doing. Then there is TCS, in which the girls are being covered for IVF. So there is a very irregular, disorganized sector around insurance. So undoubtedly, it goes without saying, it should be covered. It is not a lifestyle problem. It is just like a disease. A person might be having tubal block requiring IVF, which she may have encountered due to tubercular endometritis. So how does that become a lifestyle problem at all? So undoubtedly, this needs to be covered, and we need to cover it. Whether it is partial, whether it is complete, it needs to be seen. As far as you were talking about a central government health scheme, that is CGHS, it also gives coverage for the medications. But again, it does give cover to some extent, not the entire treatment. So as we said, that it should not be that somebody from the government sector can get the benefit of medicines, whereas somebody who is working in the private sector does not get the benefit. So that should not be a dispartite kind of a thing.
Rohan, you wanted to add something?
Yeah, just about what ma'am said, just to echo that fact that infertility is a disease now. It's no longer a lifestyle
Very
problem.
proven, very proven.
It's been established by the WHO as well. At the same time, I do understand where they're coming from, where they are saying that it's not a treatment which is giving you 100% result in a way. But then it's the same thing when you take up a health insurance or anything up like that, or a medical insurance. If someone gets a heart attack, doesn't mean, God forbid, but doesn't mean that they're not going to, if they don't survive or anything, doesn't mean that you're not going to cover the bills. It's similar. Treatments can have pros and cons as well on that. At the same time, when we are looking at somewhere around a middle ground, I think the insurance companies, along with all the national bodies, maybe need to sit together, figure out a cost where maybe you don't want to cover the entire cost of it, but maybe say the medication or the technical procedures like the IVF or the ICSI, to a point where, say, when I talked about it being between 1 to 3 lakhs, if a patient's cost is 3 lakhs, even if you are able to cover, say, 50 to 60% of the cost, that makes it a lot more affordable for the patient to actually approach and manage the treatment. I don't think we've reached a point where we've, in that situation where the insurers are going to say that we're going to cover 100%. But at the same time, I think we've reached a point where we need to start having a discussion on how much can be covered by the patient and how much can be covered by the insurance. In fact, some of the larger corporate companies, in fact, already have insurance plans for egg freezing, for embryo freezing, for infertility treatments as well. It's not much. It varies somewhere between 50,000 to around 80,000 rupees.
Around a lakh they are covering. They are covering around a lakh.
So it's not a big
amount. That is also
amount.
a help.
So the only thing that, yes, in bits and pieces, we are getting it, but the requirement is, I think, a uniform. especially what we started the conversation with, that the vulnerable population who are actually not able to access this. They are their bits and pieces, but we have to come.
Just one point I will like to make for him, because there is no control over who will opt for IVF. Because sometimes there's a couple who's busy in their corporate life. They don't have time. Sometimes they come and say, doctor, we are getting IVF done and we want twins, so it should be through. They don't have any other problem. So those type of couples, married for 1 year, they will say, no, let's come do IVF. Anyway, it is going to be free. So let's get it done. And so those type of people or couples, how will they control? Or no one can control them, and that must be their biggest fear.
Just to add to that, I think that's fair enough. That's a very good point brought up. But at the same time, I think that may include 1 to 2% of our entire practice. It's not the entire thing.
Yeah.
Another point for the things that I want to do is, generally when you do take up an insurance, there is a window period of 2 years before the insurance actually sets in. So if you do end up doing it for an IVF cycle, if you have a 36-year-old deciding to take up insurance with you, don't wait till she's 38 till the insurance
Egg freezing
sets in.
is also that only. That's social egg freezing, what we are talking about.
Egg freezing, of course, should be done at an earlier age, preferably not coming at 35 plus
But then
40.
again, it becomes that whether you want to do it as a...
I would here disagree with Dr. Mohan, what he said, that there should be a capping or a decision making on the part of the insurance company, because then again, it will become very, very difficult. It will become very, very difficult. The purpose will be defeated, because then we know how little things keep on adding. And hysteroscopy for infertility is not covered under insurance, but a hysteroscopy for polymenorrhagia or a bleeding disorder is covered under hysteroscopy. Why? So, but it's a fact. So this is what I'm saying. I don't agree with that point of view, because as Rohan said, it is a very, very minuscule percentage. In fact, we are fighting for against taboo against IVF rather than people coming forward. There are very few people who are coming forward.
Agree. Now moving to the next question, Dr. Gunjan, to you.
If I could add two
Yeah,
cents, definitely the green shoots have started coming in. So as Rohan rightly said, now at least the big corporates, tech companies have started taking corporate insurance, which does cover fertility treatment. We are also in the final stages of coming with a product which will cover retail customers. However, there would be a waiting period. So that's the point.
That's another policy we have to make, how to reduce the waiting period.
No, I think you're right in terms of considering the waiting period, but see, this is where the problem would actually lie in terms for me as an IVF specialist. That if you keep a waiting periods of say 1 year or 1.5 years or even 2 years, which is the standard waiting period, I think for most health insurances, the issue arises that if I get forget a 35-year-old, say I get a 33-year-old with a good prognosis, but her waiting periods for 2 years and she can't afford it and she decides to come after 2 years, by then I've lost that window in which I could have actually given her a success rate, and then Mohan sir, I have to approach to make sure that we get her pregnant.
And the cost increases.
Maybe you can increase the premium rather than increasing the
Duration. So these are the good suggestions, I think, and now let's keeping the time in mind. So my next question is to Dr. Gunjan, to you. We know that there is a rising demand of the treatment, of IVF treatment in the tier 2 and the tier 3 cities. What innovative economic model have worked for affordable IVF and have proven viable? And what system changes are needed to make fertility services accessible to the tier 2 and tier 3 people?
Yeah, that's a very, very important and a valid point, because till I would say a few years back, IVF was limited to the metros and the higher cities, and that is why it became more associated with a lifestyle rather than it actually being a disease. Definitely we know that it is not only tier 2, it is the tier 2, tier 3 which are having the maximum number of patients, and for whom the right kind of services are not available, because it is based on 3 things. See, when we talk about tier 2, tier 3, it is, one thing is the affordability. The other thing is the accessibility, and the third is the awareness. So we have to work on all these three pillars. One is affordable, how do we make it? I feel the best model which works, best quality care is if you work on a hub and spoke model. I really am a promoter, because what happens when we open a hub, we make a lab, it has its huge cost which comes along. And if we attach it with a spoke in this tier 2, tier 3 cities, because now our entire services are so good, the roadways are good, the connectivity is so good, why not utilize it to your advantage? And also with the use of technology in it. I'll tell you what I mean by that. See, one thing, as I said, the spoke can be used for giving the right kind of care. You have doctors who will start the proper stimulation, because the stimulation process takes 10 days. Why the patient has to come in and out daily? So the ultrasound monitoring, the treatment protocols, everything can be decided, and she needs to just travel twice to a hub. So that reduces her cost. As Rohan pointed out, it is not only the cost of it is not only the cost of procedure, the cost of travel, the cost of stay, and also the work loss. Because if that 10 days she's spending here, what is the person doing 10 days? So he's also losing on the wages. So that is where a huge cost difference comes when you work on a hub and spoke model. Now the question is, when you are working on a hub and spoke model, how do we standardize it? Best way is the use of technology is what I feel. By technology, I mean if you have digitalized system in which the person sitting at the spoke can monitor. For example, we have got very strong FMSs in which we monitor all our centers, and they are indigenous. We have built them in-house, and we can monitor sitting here that how many patients are being stimulated, what is the protocol which is being done, and how do we have to do. If there's anything there is an organized system, because when you are following a protocol, you will know that yes, things are going wrong or right. Of course, you cannot rule out the clinician's skill, but still standardizing the procedure helps. For example, if you have standard procedures, on this, the person comes on day 2, these particular things will be done. On day 7, this particular things will be done. So then it is unlikely to be wrong. So very strong processes connected digitally helps a long way. So this is what I feel it helps in then sort of standardizing the procedure. In fact, in that, I would like to make a small submission that we have made an algorithm on the doses also. And in fact, we have submitted in ASRM, where it has been accepted. The paper has been accepted, in which we have optimized the cost of, optimized the doses of HMG on the basis of antral follicular count, AMH, BMI. And also if the person has been stimulated in the previous cycle. And in fact, we put in all the factors. We did a regression analysis of our patients of the last 3 years, and have brought out an algorithm in which my daughter, who is an engineer, she did all the calculations, and we submitted it, and it has been accepted in ASRM. And the best part which has come out of that is that the dose which we are actually giving is much more than what is required. Of course, the further part has to be done, like now we'll be doing the testing process of it. When we are giving these doses, how do we do? So what I'm trying to say is that using AI, using digital, and working with clinical expertise will go a long way as to how we can reach out to the tier 2 and the tier 3 cities. Other thing is, of course, doing outreach OPDs, bringing awareness. Then very important is doing conversation with the people, it is very, very important. Like we do a lot of education campaigns, and that starts from schoolgirls. Because if they are not free to talk about reproductive medicine now, they will never be comfortable in talking later. So that is where the awareness about the reproductive medicine is very, very important. Even the corporates, it's very important to talk to them, because we may feel people are very educated. But when it comes to talking about reproductive medicine and fertility, they are not so open about it. And then they will not be reaching out to the correct people whom they should. So it is how we need to go deep down into the tier 2, tier 3 cities to bring about awareness in this condition.
Absolutely agree. I think the whole point is that we should set SOPs, use the new technologies, AI and everything, and work together. Yeah. And the main important what you highlighted is the awareness. If we want to reduce this and reduce the rate of infertility and get our TFR back or improve it, yes, awareness needs to be targeted from a right age and not only making the patient treatment. Now, moving to the next question.
Just one more point I'd like to make here is that we should use telemedicine also more. Because, again, there is a little problem there.
I will be coming to you in a detailed conversation regarding that. So my next question to you, Rohan, that what policy reforms or what financing models, let it be public-private sectors or social inclusions, outcome-based pricing, what health policy? Because we see that still many health policies are not including IVF treatment. So what, according to you, should be the best model or a mixture of many models which can help to improve this?
I think that's a very good point. As I said before, the public-private partnerships is something that would really help out. In fact, I love what Gunjan ma'am said about the hub and spoke model. Now, if we look at Mumbai alone, I'm not going to go outside that because my geography is pretty good here. We've got close to KEM Hospital, we've got JJ, we've got St. George, and I'm just talking about South Mumbai. We've got Cooper, we've got Sion, we've got Nair. If you do a public-private partnership with these places, in the sense that, say, I have a private IVF center and they tie up, in a way, if there's a referral or there's a voucher system that comes from these hospitals where you can either provide it at a subsidized rate or where the government covers the cost based on the voucher system, which it will help the patients also get access to it. Plus financially it'll be viable not just for the patients but for the IVF centers as well. Because over there, when you can do it at a subsidized rate, why not? Number two, maybe the Ayushman Bharat or the ESIC which is there, if somehow that can get incorporated, that can cover IVF into this, that's also going to play a big role in managing it. We've been talking about the ART registry for the longest time, the National ART registry. So say if you do get tied up with a public-private partnership in that sense, you'll be pushed to push out the registrations. You'll be able to understand the audit. The audits will get better in terms of what are the success rates, what are the failures. It'll also help in creating transparency between the government and the IVF centers in handling such models. It'll help the insurance company guys also to get details, the data, so that then they can create policies for the private sector which are possibly not a part of this as well. So these three main factors could be something that could be incorporated in order to ensure that the financial stability for the centers is there, as well as financial equitability is there for the patients in terms of everyone being able to afford these centers as well. I'm not going to take too much time because I can see that we barely have 3 minutes remaining.
So I will move to next question to Dr. Mohan sir. Now, we know that niche fertility concerns like reproductive immunology, and when we talk about the structural reforms required to integrate these problems into mainstream treatment coverage, what policy discussions ensuring that this all treatment should be included in the ART ecosystem?
The most important thing is all clinicians or IVF doctors or fertility doctors must be open to the idea of use of reproductive immunology techniques and should make up their mind for sure that yes, if the patient has alloimmune problem related to IVF failures or miscarriages, she is likely to be benefited if the right choice is done. So many centers are doing, they are incorporating these investigations into their regular investigation panel, especially if the patients with previous failures are their IVF failures. As a first line of investigation, the immunological investigations are included, as I think Dr. Rohan's center does that, so that the reports are ready and the diagnosis is very quick, treatment is very quick, and the patient undergoes next subsequent cycle without losing much time. And at the same time, at what stage this should be done is entirely at the discretion of the doctor. An elderly patient who has one failed IVF cycle or maybe miscarried after an IVF cycle would require these investigations earlier than someone who is younger. But at the same time, you have to keep that thing all the time in mind. And then I think this will definitely help in reducing the number of cycles. So if incorporation of reproductive immunology related investigations and the right treatment at right time, like the patients are referred to us, as I said, after IUI, we specialize in a particular treatment called lymphocyte immunization therapy, which we have a patented process of Imulit. So this has helped so many patients reduce the number of cycles that they are undergoing, which is effectively helping them in reducing the cost. So therefore, I feel as a policy, if that is incorporated in the management of IVF cycles or the investigations of patients who are undergoing IVF, I think definitely that will become a part of IVF treatment, and it will, in a long run, it is going to definitely help patients being successful with less spending or maybe undergoing less number of cycles or trauma.
I think now we have to rush our session to wind up because we are running short of the time. So my next question to Mr. Vikas is, how can the insurance ecosystem be encouraged to adopt the fertility care as a core offering? What all forms? Let it be underwriting, a product design, or a strategic alliance. What's your expert view? And I think in few elaborative points.
Thank you. If I just go back to the earlier point you said, we have now insurance for surrogate mother, donors. They all had the backing of a regulator. So you had ART regulations, you had surrogate mother, which mandated. And we were the first one in the country to come up with the donor insurance for surrogate mothers and oocyte donors. But I can tell you, when we had started, there was only one company through us that was happening. There was multiple meetings where Ministry of Finance, Ministry of Health, along with IRDA, had been pushing the insurance companies to come up with the product. So the point I'm trying to make is it's very, very important that the regulator, we encourage IRDA to issue guidelines to have minimum standards for IVF treatment. And this has happened in past also. We have had a regulatory dictum coming for various treatments such as HIV, mental cover. All those things were mandated by the regulator to the insurance companies to come up with the product. Second, the most important is the data. It's very, very important that we have a national registry which is able to identify, provide actuarial valuation in terms of the pricing, in terms of categorization, which is very, very important for an insurance company to price that product. And the third is innovation. There has to be a partnership between companies like us, InsurTech, players in the sector, where we could come up with the pilot projects, understand the learning from it, and then scale up at a national level. But definitely, if I were to state, I definitely believe there is a need for insurance. The latest UN report on population definitely said, especially south of the country, where the fertility rates are so low, definitely there is the need for it. And I can assure that the winds are moving in the right direction, and hopefully we should have a IVF product, and from an aspirational product to a reality.
Thank you so much. And moving to the last question of this panel discussion, to Dr. Gunjan. And first, I want to congratulate you for your ASRM acceptance of the paper. Now, you were already talking about the teleconversations, how to spread the awareness. Now, do you feel that these grassroots awareness, the telemedicine and decentralized care models can help to bridge this fertility care gap? What's your opinion about it?
Yeah, I'll keep it short since the time is already up. Basically, yes, telemedicine is which should be utilized more in our country, and that is really, really important. Because at least if not for a proper prescription writing, for opinion, because then people in far-off cities, far-off places can have an access to that. If internet is there at every level, then why not telemedicine is my take into it. And then everybody gets a correct second opinion as well. They may be undergoing treatment with whichever center, but yes, they can take an opinion, they can take a second opinion, and we should become fair in giving opinion. That is also very important. When we are talking to somebody, we should be very, very fair about what we are talking, because it is very important to the patient, because they will always be sort of interpreting things in a different way. So we have to be very watchful for our words. But yes, telemedicine is the way which should be utilized more by a country, because even telemedicine has its limitations. There are a lot of rules and regulations around it. That is the problem why a lot of people are reluctant in using it. So we need to make the laws also slightly more flexible, give doctors also a little more autonomy so that they can do things. And of course, that will come to an advantage to people who are residing in far-off places, that they can take proper advice from experts as well.
Thank you so much, and thank you all for being part of this meaningful discussion. And I'm sure today's panel has made it very clear that affordability and equity must go hand in hand. And financing fertility isn't just about the cost. It is about the access, the agency, and the justice. So I thank to our incredible panelists for your insights and for a lovely engagement.
Thank you, Navina, for moderating it so
Thank you.
beautifully.
Thank you so much, ma'am. Let's have a round of applause for our panel of experts. That was a strong and honest discussion, wasn't it, Kanishk? And these are the conversations that push the envelope, that remind us IVF is not just a medical service, it's a human right that should be affordable, accessible, and equitable. And thank you for our incredible panelists for shedding light and expertise on this problem. And now I would like to invite Ms. Navina Singh to please felicitate our experts for the panel discussion. Dr. Rohan Palshetkar. Let's have a round of applause for our speakers. Dr. Gunjan Gupta Govil. Mr. Vikas Anand. Dr. Mohan Raut. Thank you so much, sir. Now I would like to invite Dr. Gauri Devi to please come on stage and felicitate Dr. Navina Singh for excellently moderating this discussion. Let's give her a round of applause. Can you please come on center of the stage to capture, to take a photograph, please?
Ladies and gentlemen, let's give it up for the fantastic panel, which was definitely quite productive here for us.